which is what I'm doing this weekend. So I'm going to go ahead and get started and just talk to you guys a little bit. I've been asked to talk about prescribing contraception, and this is a lecture that I gave a couple of years ago, but I think it's always really nice to have a good review. For those of you who have rotated with me already, I don't see any familiar faces. This should be a really great review. And for those of you who are yet to rotate with me, this is a really good review as well, because we do a lot of this when we're on PAG. So the first thing to realize is why? Like, why do we need to prescribe contraception for adolescents? And this is the reason, because we know that for women who were between the ages of 15 and 19 who are at risk for an unintended pregnancy, so sexually active, within the last 10 or 15 years, 82%, the statistic is 82% were using a contraceptive method. But when you look into that, they say 55% of them you were using a condom and 20% of them were using withdrawal. So that means that 75% of them were relying completely on either a condom or withdrawal to prevent a pregnancy, which I think we can all agree is probably not ideal. And then you are looking again at a very large proportion using something like an oral contraceptive pill. Sorry, I'm trying to get my laser up. An oral contraceptive pill, which again is not my favorite method in an adolescent. And so I think that there's a lot of room for improvement here. And I think a lot of that drive needs to come from us as healthcare providers. And so that's one of the reasons. This is old data. The data always lags behind. And definitely South Carolina has been decreasing in its rate of teen pregnancies. That is actually following a national trend. So that is pretty good. We are still higher than the average in the country. And so if you think that's a really high number, 90 patients in 2013, or 90 pregnancies in 2013 to women under 15. And of those, over half of them actually went on to give birth. So those are pretty horrible statistics. And then if you look at the actual births between women 15 to 19, that's pretty significant. So I do get a lot of questions about access to contraception and who gets access to contraception. The answer is that everybody's supposed to have access to contraception. And that was one of the hallmark pillars of the Affordable Care Act. There are clearly exemptions to the Affordable Care Act. The big one is religious employers. And so that's something to think about. I will say here, the biggest problem that I have with access to contraception is actually Blue Cross Blue Shield State, which is actually the largest private insurer in the state of South Carolina. So anyone who's employed by, for instance, U of SC, has Blue Cross Blue Shield State. And Governor McMaster signed an executive order a number of years ago that said that any minor who is on their parents' Blue Cross Blue Shield State plan is not eligible for contraception for contraceptive reasons. So if you think about it, one of the ACA hallmarks was that minors can be on their parents' insurance plan until they're 26, which is marvelous. But if they're not going to have any contraceptive coverage in South Carolina's largest insurer, that can possibly be problematic too. So it's just something to think about as you're trying to navigate this world of contraception. But clearly, I think that this is something that y'all should be doing. And, you know, and that's a culture that can be hard to change, because I know that historically, pediatricians in Columbia have been a little bit reticent to provide contraception, and they've been a little bit more comfortable referring them. And, you know, when you go into private practice and you make your decisions about what kind of practice you're going to have, that's something that you can think about. But a dollar that's spent on publicly funded contraception can save the healthcare system almost $6. So something as simple as contraception or familiarity with easy and early access to contraception can actually have huge cost saving measures nationally, and also huge implications for your patients, because obviously we also use contraceptive methods for non-contraceptive reasons. And in fact, I would argue that overwhelmingly in my adolescent population, I have non-contraceptive uses for contraception as the majority of my visits. Okay. And so there's a lot of different reasons that you can see outlined there on the screen. Who is an eligible candidate? Well, anyone who asks, almost always. Okay. So if someone comes to you and they say that they want to initiate a contraceptive method, and they're post-menarchal, that for me, that's a big thing. They need to be post-menarchal, preferably. for a hormonal method anyway, then that's reasonable. And every so often, especially over in my 1801 population, which is not hugely dissimilar to your chalk population, I have girls who haven't had sex yet. And I do have the occasional resident who's like, why would I start her on contraception? She's never had sex. She's come to you. She says she wants to be on a contraceptive method because she's worried she's at risk for a pregnancy. That's a great reason to start her on something. Historically, there used to be this idea that to prescribe contraception, a pelvic exam was required. That is not the case. I haven't heard that hugely often anymore, but if you've ever heard that, that is no longer recommended. A pap smear is not necessary. And you can perform STD testing on the same day. So I've heard that too. Oh, she comes in, you need to talk to her about contraception, get her STD testing, and then have her come back so you can actually write the prescription. That is not the case. Okay. So we're really trying to make sure that we're making contraception available to patients who need and ask for it. This is something that I really recommend that you download, particularly if you're going to be in any sort of generalist pediatric practice moving forward. These are the CDC medical eligibility criteria for contraceptive use. We call it the CDC MEC for short. This is updated by the CDC regularly. And what it does is this like very complicated looking graph tells you what kinds of contraceptives are safe with different kinds of medical conditions. So if you were ever like, oh, I can't remember, like, is sickle cell allowed to be on a pill? Like, I can't remember if that's a contraindication. You can go straight to this chart and you can look it up. Better yet, there's an app that is free, and I highly recommend that you download it. And it's actually really easy to use. And you can search for contraception either by method or by condition. And so I think that's really fantastic. So I encourage you to download that. There's also a really great concept that comes out of the CDC, which is something called the reasonably certain criteria. And this is also available on the app. The reasonably certain criteria allows a clinician to make a reasonable assessment of whether or not a patient is pregnant. And I have used these many times. For instance, if I'm performing an emergency surgery, or if I'm waiting on a pregnancy test to come back for anesthesia because I'm taking someone for a procedure, and I've been able to say, I can be reasonably certain this patient is not pregnant because, for instance, she has an IUD in and she has been correctly and consistently using this reliable form of contraception, right? It's pretty hard not to be reliably using an IUD, right? So does anesthesia always believe me? No, but I argue it every time nonetheless. Okay, so these are really nice things to think about, because say you have someone who comes into your office and you decide that you're going to refer her to me, but you don't want her to get pregnant in the meantime, because that happens, about 5 or 6 times a year that I get a referral from Chalk. And then by the time she makes it to see me, she's pregnant. So that happens pretty regularly. Say you decide, actually what I'm going to do is I'm comfortable giving her a pill prescription, like just a month or 2 while she's waiting to get into CPAG, but oh my God, how do I know? And like, she doesn't want to run a UPT. Well, if she's within 7 days after the start of a normal menses, you can be reasonably certain that she is not pregnant. So it can give you a lot of really good clinical guidance. So what do adolescents want when they're given the chance? Okay, so when all cost barriers are removed, overwhelmingly, adolescents actually choose LARC methods, and LARC stands for a long-acting reversible contraceptive. And the 2 classic examples of that are the Nexplanon implant, which goes inside the arm, and the IUD, which is placed by a provider inside the uterus. So that's pretty impressive, right? So in the younger cohort, not surprisingly, they overwhelmingly choose the arm implant. And then in the older cohort, they overwhelmingly choose an IUD. So I think that's really fantastic. And not only would they choose that if you removed all the cost barriers, they continue them at the same rate as adult women. So that's really fantastic. So sometimes people are like, oh, who would invest all this money putting in this really expensive device in a kid? She's just going to change her mind later. They don't actually. And so that's really nice. Moreover, when you take away those cost barriers, there is a 75% reduction in pregnancy, birth, and induced abortion. So that's pretty impressive. And so that's something else to think about, because here at Prisma Health Midlands, at Prisma Health Richland specifically, we do have the ability to eliminate all cost barriers. And at 1801 Sunset, we have received a grant. It's called the Choose Well grant. And if a patient chooses to have an IUD or an implant, it can be put in, I think it's $50 for the visit. Okay. Whereas if you wanted to have me put in your implant in my private office, it would run you a whole lot more than $50. So that's pretty fantastic. And so knowing that you have that availability, if you have, for instance, a kid who's self-pay but sexually active and expresses an interest in having an implant placed, you can refer them into us as a Choose Well site, and we can help them secure that contraceptive free or low cost. So what does the literature say? Y'all are super duper duper important, okay? Pediatricians play a key role in managing sexual health and contraception because you have these long-term relationships, particularly with adolescents and their families. And so I think that that's really important because abstinence-only education, which unfortunately is the modus operandi in the state of South Carolina, has made it really challenging to provide factual and informed medical care to some of our patients about things like cancer or concerns that certain medications are abortifacients. And so it's really important that you guys recognize and appreciate how important you are in this area of sexual health, particularly for your adolescent patients. But I recognize that it's scary and it's intimidating and it's often outside of your comfort zone. And so a couple of things to think about when you're getting started. So say you have this very, very brave 16-year-old who shows up to your office and the purpose of her visit is I want to establish care for contraception, right? And I get that one a lot too. And I can see that they were in chalk and I see some really great notes coming out of there. But the first thing to say is, reassure them, okay? They're usually pretty nervous coming into you. And part of the reason that they're nervous, definitely when they come to meet me, is they really think that they're gonna get a pelvic exam. Overwhelmingly, that's why they're nervous. Someone told them, we're gonna put you on some birth control, but they gotta put these big metal duckbill things on up in you, and you just lay there and you just try to, look at the stars and it'll be fine. It's part of being a woman. Oh my God, that's horrible, right? So a lot of times that's been the dialogue coming into your office. So setting the scene and say, hey, it's so nice to meet you. I'm so glad that you're here. We're going to talk about this. I realize you might be really nervous. And sometimes people are nervous because they think I'm going to do some sort of scary exam. I'm probably not going to do that today, unless of course something comes up that thinks that that makes me think that I need to. Obviously with adolescents, we always want to make sure there's that confidential component to the interview. And I will often save my sex questions for then. I will always do that. There are some obvious things, trying to sit lower than your patient, facing them, making sure you have good eye contact, and making sure that you're asking positively framed, open-ended questions. And so that can sometimes be helpful too, because the other thing I will often see is it'll say purpose for visit, birth control, but it's actually like a 13-year-old with dysmenorrhea. And all of her friends went on a birth control pill and she just wants to go on a birth control pill too. So it's not actually for contraception at all. So if you walk in and you say, I see that you're here for birth control, when she's not, she's here for management of her dysmenorrhea, that can maybe sometimes get people's backs up as well. So just thinking about your words. And then, of course, asking about sex, it's so hard to ask about sex, and I know that. And as you go through your training, trying to figure out a way that works for you, that's more comfortable, will definitely go a long way. So asking things like, are you sexually active? Generally not something I recommend. Most teenagers don't know what that is, so they just say no. If you say something like, have you been sexually active before? A lot of times they'll say no. But if you say something like, sex can mean lots of things. This is usually something along the lines of what I say. Sex can mean lots of things. For me, it usually means any sort of contact or touching below the belt. So that can mean like penis, vagina, mouth, penis, mouth, vagina, finger, vagina, any of those combinations. Is that anything you've ever tried? And they'll be like, oh yeah. And it's amazing because the resident will come in and say, oh, she's never been sexually active. And I'll go in and ask that question. And they're like, oh yeah. Yeah, I've done the butt vagina one. Does that count? Or I've done butt penis. Like, does that count? Yeah, that counts. And that's important for me because then as I'm screening you for STDs, I know what orifice I'm screening you in appropriately. So thinking about that as well. And obviously outside of the scope of this particular talk, but in my personal practice, I make it a very clear point to ask about gender identity, sexual orientation, and who people have sex with. Those are not all the same thing. And so thinking about incorporating that into your adolescent interview, I think is also important. There is this concept of motivational interviewing, and this is one of my favorite ways to talk to an adolescent about contraception. So is that something you guys have ever heard of before, motivational interviewing? Yeah. Okay, good. So, it's this idea that it's patient-centered counseling style to help patients identify where they could have behaviors that change so that they can make a positive impact. So, like an example for contraception is, and this is actually a paper that I published as a resident, believe it or not, because I worked in a teen pregnancy clinic that we had, and we had really high rates of LARCs in our postpartum teenagers, and we use this system. So when would you like to have another baby? Helping your patient identify when that might work for her. Do you have anything you might want to accomplish before you have another baby? And she says, yeah, I want to go to beauty school. Great. So if you want to finish high school in 2 years, and then you want to do another 2 years of beauty school, is that right? It sounds like you want to wait at least another 4 years till you have a baby. Is that right? And she's like, actually, yeah, that is right. I hadn't thought of it that way. Great. Did you know you can get pregnant the first time after you have a baby? Do you know of any birth control options or any ways that we can help you so that you can wait another 4 years if you want to have another baby, and I can give you those options? And we were able to show in our cohort that for teenagers who received this motivational interviewing compared to the cohort that was in the regular resident clinic that didn't get this, our rates of uptake for LARCs were almost 4 times higher, okay, using motivational interviewing. So that's a really nice way to show that. And I'm going to just breeze through this because you guys have familiarity with that. When you're counseling, I know anyone who has worked with me, we use this sheet a lot, and anyone who spent any time at 1801 PAG, we use this sheet a lot. It's actually off the market. It's being changed and updated, but you may see copies of this floating around. I just use it because I think it's nice to have things that have pictures and are in color. The other thing that I have in my office are lots and lots of models. So I have a little birth control basket, and I can bring that in so that patients can see and touch and see what's going on when they are trying to make a decision about a contraceptive method. The other thing that's really helpful is to have patient resources. These are the 2 most common ones that I use, and they are both freely accessible to you. So over there on the left-hand side is the NASPAG. This is the North American Society for Peds and Adolescent GYN. This is the NASPAG website. It's free. And if you go over to their main site in patient education, they have tons of handouts in both English and Spanish on different contraceptive methods. And they even have a really great handout on using hormonal management for non-contraceptive reasons, which I think is a really good one to have. The Center for Young Women's Health is run out of Harvard. It's a phenomenal website. There is also a Center for Young Men's Health, but they have a lot of free, really great information and handouts as well on different forms of contraception. Going back to what we were talking about before, this is out of our American College of OBGYNs, or ACOG guidelines, and they straight up say that fear of a pelvic exam may prevent adolescents from seeking contraception. So I just put that in there to reiterate to you how very important it is to lead with that if you have a patient who comes in and may not necessarily require a pelvic exam. Obviously, this is a somewhat old presentation because that's still Cerner, but Epic also has the same thing. It still has the same STD panel where you can check for gonorrhea, chlamydia, and trichomonas. Please check for all 3. There's no point in checking for gonorrhea and chlamydia and missing the trick. It's the same sample. And you can get that off of an endocervical swab or first catch urine. And you're like, well, why would I do that? Because say ACOG and AP recommend that you test for gonorrhea and chlamydia at least annually in sexually active adolescents. Okay. So I'll sometimes have a resident come in and they'll say, Marianne came in today. She's 17. She's on depot for her birth control method. She's just here for her annual check-in, but she says she doesn't want any STD testing because she thinks she's fine. No, Marianne is going to get STD testing because she's a sexually active adolescent, and we're going to follow those guidelines. And the reason behind that is simply because adolescents are such a high-risk group. In my personal practice, I definitely recommend that you screen a sexually active adolescent with every new partner at a minimum, and I offer that screening every time they come into my office. But say you do have Marianne who comes in and she's like, she doesn't think she needs screening because she's been with the same guy for the last 2 years and she feels like she's good and she has no pelvic complaints and no discharge and no nothing. Well, Marianne's a perfect person to get first catch urine in. You don't need to do a pelvic exam to get a swab. You can get it off of her urine. And the other thing to remember is that self-collected vaginal swabs can also be okay. So sometimes I'll have a patient, I'll give her swab, send her into the bathroom, and she can swab herself, and that's okay too. I'm going to start moving into some of the different contraceptive methods, but before I do, does anyone have any questions so far? No, hopefully more of you have joined us. All right, so Nexplanon. I'm going to start with Nexplanon, and the reason I'm doing this is very strategic. Historically, like back when I was a medical student, which I feel like wasn't that long ago, but which was a while ago, we were always told that you start with the pill. When you're counseling an adolescent, you start with the pill, and then if that doesn't work, you can talk to her about other things. And that is not the recommendation. Okay, that is not the recommendation any longer. You should start your counseling with the most effective method first, and then move on to other things. Okay, so just that's another really useful thing in your counseling. The most effective method is Nexplanon. Nexplanon is more effective than having your tubes tied, but it is totally reversible. So it's kind of a cool birth control method. The pregnancy rate associated with Nexplanon is literally 0.05%. It's pretty exceptional. This is a progesterone only medication that's placed into a matchstick sized rod that's placed into the arm. It is bendable and flexible, and it's placed easily in the office in a procedure that's under 5 minutes. It is FDA approved for up to 3 years, though we do know that in normal weight women, it is good for contraceptive efficacy for up to 4 because that's how it's used in Europe. So that might change. And it's what we call a set it and forget it or a LARP method. Okay, so the patient comes in, she gets her birth control, and she walks out and she never has to do anything about it again to make sure that her birth control is working for her. I love it because it's progestin only. So we'll talk a little bit later about complex contraception and who might be a candidate for estrogen and who might not be. It's clearly very discreet. But the thing to think about, which you can put this in the pro or the con category, is that it has an unpredictable change in a patient's bleeding. Okay, so for instance, we're going to talk a little bit later about things that always give you a shorter and lighter period. And this isn't one of those things, right? So you divide your patients into 3 groups. One of those groups, they're not going to notice a significant change in their period. One of those groups are going to notice that their periods become lighter or possibly even absent. And one of those groups is going to say they don't get a period so much, but they might get breakthrough bleeding or spotting on most days. So for my teenagers, I always tell them that they need to be prepared to potentially wear a panty liner every day if they have an Nexplanon placed. Now, a lot of my teenagers are like, meh, fine, I do that anyway. But for some patients, that would be really bothersome, okay? And that bothersome bleeding is actually the most common reason why Nexplanon is removed. The other con, obviously, is that it needs to be inserted by a provider, okay? And so this is really relevant. Say, for instance, you have got a socioeconomically disadvantaged 16-year-old, right? So the age of consent for sexual health services in the state of South Carolina is 16. So if a 16-year-old comes in your office and says, I want to get started on Depo because I'm having sex and I don't want to get pregnant, you can do that. She has the right to say that at 16 and up without a parent present or consenting to that. So say you have a socioeconomically disadvantaged 16-year-old, we see a lot of them, right? And she comes to you for birth control, or she calls for a telehealth visit because she lives in Manning, right? And she doesn't have a car, and she wants birth control and she really wants this, that's a problem, right? Because this needs to be inserted by a provider. So that's just something to think about. I've been getting a lot of questions of late about whether or not it is associated with weight gain, and the answer is no, it is not. Moving on to the IUDs. So IUD stands for intrauterine device. There are 2 broad categories of IUDs. There's a hormonal and a non-hormonal. Within the hormonal category, there are currently 4 hormonal IUDs, and they're different based on their size and the amount of hormone that is in them. The copper IUD I will talk about separately. So the hormonal IUDs all have the same hormone in them, which is levonorgestrel. Again, this is a progesterone only method, which is really discreet. Okay, these pros have actually changed. I haven't updated this slide in a little bit. The FDA actually just approved Mirena last month for 7 years. Okay, so Mirena specifically is good for 7 years. Liletta, which is one that we use very commonly over at 1801, is good for 6. Kylena is good for 5, and Skyla is good for 3. So you've got some really great long-lasting contraceptive efficacy with any of these. And the other really nice thing about them is they overwhelmingly have a positive impact in patients bleeding. So greater than 80% of women will bleed for less than 2 days a month with an IUD in place eventually. Now, they may have some breakthrough bleeding or spotting while they get to that point, but overwhelmingly, it has a very positive effect on bleeding, and a lot of women like that. But again, this is something that needs to be inserted by a provider, and this is something that has had a complication rate that's really been advertised, okay? So late night lawyers love the IUD, and you'll see things like this, like your Mirena surgical removal lawsuit, call 1-800 sue your OB, you know, like it can be really hard. The things people worry about are perforation, which means that the IUD somehow makes its way into the peritoneal cavity. The risk of that is quite low. It's less than 0.1%. More commonly, lost strings, which generally are able to be remedied in the office, but not always. And then finally, an expulsion rate, which can be cited I cite for my patients anywhere between 2 to 7% expulsion rate. So generally around 3 or 4 is reasonable to quote. The copper IUD is a little bit different. I don't like that picture because it makes it look really rigid, but here I'm going to show you an IUD. This is a hormonal IUD, but it's similar in its consistency. So this is the size, and you can see it is a really bendable, stretchable, flexible device, okay? And so the copper IUD is the same, even though it doesn't look like that in the picture. The copper IUD has a lot of appeal for patients because it is a non-hormonal, long-lasting and effective form of contraception. The copper actually inhibits sperm motility and creates a hostile environment for sperm, and that's its mechanism of action. This is a long-lasting method. It's FDA approved for up to 10 years. Again, though, we know that it has good contraceptive efficacy for up to 12. And so that's really nice for a lot of my patients. And the other benefit for it is that it can be used as emergency contraception, which is a specific form of contraception that we're going to address a little bit later. Because it's non-hormonal, generally I advise patients that their bleeding is going to be about the same as it is. So if you have a patient who has irregular periods and she's like, I want an IUD because my heavy and irregular bleeding is bothersome, this isn't the thing for them, right? Because some women actually do report an increase in cramping and bleeding. Overwhelmingly, that tends to go down after about 6 months of use, but it is something to think about. And again, this is something that needs to be inserted by a provider, but this is a super great contraceptive method. Same-day LARCs are getting a lot of press right now. And what a same-day LARC means is that a person presents to your office, you talk to her, she decides, or maybe had already decided that she wanted a LARC method, that long-acting reversible contraceptive method, and you go ahead and you place it the same day. And that may be a little bit less relevant for you, but OBs were always taught, no, she has to come in, you talk to her, you get her STD testing, you send her away, and then you bring her back for her insertion. And ACOG has really tried to get us to move away from that because they recognize that having multiple visits to a provider is a barrier for care for all women, but particularly for adolescents. Okay, so they said that you can test for STDs and place LARCs on the same day, and that you can quick start any form of contraception, again, coming back to this reasonably certain criteria. So this is a great clinical application of that little chart. Here at Richland, we have a really robust postpartum and post-abortal LARC program, partly because of the Choose Well program that we have. So we know that adolescents particularly are at risk of at high risk of a short interpregnancy interval, meaning that they're more likely to have rapid repeat pregnancies, and that they also have a very, very high rate of no-showing to their postpartum visits. So again, historically people used to say, oh, don't worry about the birth control, we'll talk about it when you come for your 6-week postpartum visit. Well, most adolescents don't show up for that visit. So you've sent this girl out into the world already with an adolescent pregnancy and now with no plan to prevent another one from happening. So we do a really great job in our offices, and my residents in particular do an excellent job at counseling patients through their pregnancy on different forms of contraception. So we have a plan by the time they get to the hospital. And a lot of our adolescents do choose to have an IUD or a Nexplanon placed before they leave the hospital. And what we do is we actually place the IUD inside the uterus. There's a couple ways you can do it. You can do it this scary way. Don't forget she has an epidural, so it's not as bad as it looks. Or this way, immediately after the placenta is delivered. So that's good to know if you guys see anyone that we have that as an option here at Richland. Depo-Provera is another really popular choice, particularly among adolescents. This is yet another progesterone-only method that does pretty well at preventing a pregnancy. Typical use failure rate is 6%, perfect use 0.2%. You're like, that's a huge difference. I don't understand. It can be hard for teenagers to get to the doctor to get their injections. So that's where that discrepancy comes from. And of course, that's one of the cons of this method. So this is an ovulation suppression method. Okay, so it's a progesterone only. It's given every 3 months, typically in the office. And what it does to bleeding is generally most patients experience some breakthrough bleeding spotting while their body gets used to it, and then result in a relative amenorrhea. And the statistic is that in teenagers, about 70% have a relative amenorrhea by 6 months of use. So that's by their 3rd dose. Okay. There's no decrease in efficacy based on BMI, which is really nice. We can't say that about all of our methods. And for some of our patients who have seizure disorders, we also know it can decrease seizure frequency. But the problem with Depo-Provera for some patients is that it's a shot, and not everyone wants to get a shot. It can be associated with weight gain. And this is the only method that I have that can be associated with weight gain. Sorry, I got distracted by everyone on their phones. What else? The other thing is there is an FDA black box warning that says that you should consider transitioning to another method at 2 years of use. The idea behind that was based on some studies that came out of the early 90s that said that girls who are on this have a decrease in their bone mineral density. A lot of that data has been revamped in the last 10 years. And we do know that girls who are on this can have a decrease in their bone mineral density, but it is not associated with an increase in fracture. Okay, so for me in my personal practice, I continue use. I engage my patients in an informed, shared decision-making process. And if they say they really like it and they want to continue using it, I document that they're aware of this potential risk and that they want to go ahead and continue to use it. But that is something that I get a lot of referrals in from pediatrics family practice. You know, someone will come in for their, generally out in my more rural settings, they will go in and they'll say, oh, you're at your 2 years. I'm not going to give this to you. You're going to need to go in to talk to Pete's GYN about another method because you can't use this anymore. And on more than one occasion, by the time they get to me, they're pregnant. So that's something to think about. Okay, you don't have to stop them. The other thing to think about, less relevant for you guys as peds, but definitely for my OB residents, there can be a delay in fertility up to about 9 months. I will say anecdotally, my teenagers, if they miss one shot, I feel like they get pregnant instantly. But of course, my adults who are on Depo and want to have a baby, it usually takes like up to 9 months to wear out of their system. Depo-Provera is actually pretty easy to prescribe. I talk to my patients about this being a convenient injection that you only need to come see me 4 visits a year. You don't see me for every visit. I check on you when we start. You see my nurse for dose number 2. I check in at dose number 3 just to make sure things are really good. And if they are, I see you once a year, and all those other visits are nurse visits. Okay, so it's not like you're waiting to see the doctor every time. The dosing can be anywhere between 11 to 13 weeks. And so this is the Depo perpetual calendar. It's kind of cool. So you know that if you gave the Depo on February 14th, she's going to be due between May 4th and May 18th for her next shot. Of all of the contraceptive methods that I have, I get the most questions about the oral contraceptive pill. So I'm going to spend just a little bit more time on this, just so that you guys feel like you have some more understanding. So the way that the oral contraceptive pill works is it suppresses ovulation, but unlike anything else that we've talked about so far, this has 2 hormones in it. This is the first thing that we've talked about that has estrogen in it. And the estrogen is always ethinyl estradiol. Okay, that's what the EE stands for. The progestin dose is usually 1 progestin. So like this is the famous Sprintec, which I'm sure all of you have prescribed at some point in your life. The progestin here is norgestimate, and the ethinyl estradiol here is at 0.035 milligrams. Okay, so 35 micrograms. And so with pills, there's usually some form of a progestin, typically at a standard dose, though not always, and then some form of an ethinyl estradiol. The pros of this are OCPs are really cheap. They've been around for a long time. There are Sprintec, specifically the reason you guys prescribe it is because it's on the Walmart $4 list. So even if someone is self-pay, they still have access to this contraceptive method. The pills are very small. I even have chewable pills. Those are not available on Medicaid, but there are chewable birth control pills, which can make it a little bit more accessible for some patients. And we know that it can have really great effects on menstrual bleeding, such as being able to decrease decrease intensity of periods, decrease cramps, make bleeding patterns a little bit more regular and predictable, and also improve acne and hirsutism. So there's a lot of really nice reasons why people choose to go on the pill. Everyone asks me if they're going to get fat. They're not, okay? The pill is a weight neutral medication, okay? And that has been demonstrated time and time again in an adolescent population. But there are cons, right? Clearly, this is a medication that has to be taken every day at the exact same time every day. That's hard, right? I know for a fact I couldn't take a medication every day at the same time every day. I don't think it's fair for me to expect my 15-year-olds to be able to do that necessarily. So that's something to think about. Also, now we're starting to look at the contraindications that can come with estrogen. So if you've got a kid who's on 3 different hypertensive medications because she had a renal transplant, this is not the right medication for her. If you've got someone who's a smoker, if you've got a kid who has a really severe history of migraines with aura, these are going to be contraindications for use of an estrogen-containing therapy like an OCP. The other thing that I definitely hear a lot of concerns about is VTE risk. And I know that for a lot of my pediatricians in particular, they have concerns about that, and that can often be a barrier to them feeling comfortable to prescribe this medication. I just want to put that in perspective for you. Your risk with a standard birth control pill, is anywhere between 3 to 9. So I usually say about 5 per 10,000 woman years. Okay, so your risk of a VTE is really low. Whereas if you don't put her on an oral contraceptive pill, say that's the only thing you really feel comfortable prescribing, you don't put her on it, she waits 3 months to see me and ends up pregnant, her risk of having a VTE is 65 per 10,000 in the postpartum period. So her risk has increased pretty significantly. So just something to think about. The other thing about the OCPs is despite the fact that they look benign, they're actually pretty confusing to prescribe. And so I think that's another barrier to care for people. So I just wanted to talk to you a little bit about the different types. So maybe that'll help. Overwhelmingly, I definitely prescribe monophasic pills. And in a monophasic pill, there's the same combination of both estrogen and progesterone in all of the active pills, okay? Now, that's going to be different from brand to brand to brand, okay? So for instance, Sprintech, we said, was a 35 microgram pill. My favorite pill is actually low estrin FE120. That's a 20 microgram pill, okay? But I know that in all of the active pills, every one of them has 35 mics. You can have monophasic pill packs that look different, okay? So Sprintech is a 28-day pill pack. There's 21 days of active pills and 7 days of inert pills. Cariva down here, or Desigen is another brand name for Cariva, is also a monophasic pill, but it has 24 active pills, and then it has another 3 inactive pills. And the idea behind that is it's going to shorten their pill pack. So everything that's active still has 1 dose, but it can be a little bit confusing. And the reason that I bring that, I have triphasics there in a second. And then the other thing to be really careful of is there are also 21-day pill packs. Okay, so I said this was my favorite pill here. This is low estrin FE120. This is a 20 microgram pill. And you can see here, there's 3 weeks that are one color. And then the FE here shows that there's iron in the placebo week. There's also a low estrin 21-120. Okay, so this just has active pills, and what you're supposed to tell your patient to do is just not take any pills for a week and then restart again, which I think is quite a confusing instruction in my mind to anybody, but definitely to an adolescent. And the reason that I bring that up is because I have definitely had resident physicians who have rotated with me. They know that I love this pill, so they think that's what they're prescribing for someone. But with EMR, the 2 things that come up first are this one, or low estrin FE24. And so by accident, you meant to prescribe this, but you actually prescribed this. And the problem is you told the patient to take 1 pill every day at the same time every day. Well, if you do that with this, what's going to happen? You're never going to get a period, right? And then eventually she's going to break through, bleed, and spot, and she's going to call you, and you're going to be like, I don't know what happened. So my general recommendation is if you're sending someone out, like, sometimes I'll consult on someone in house and then you're sending her out on a pill. If you are not confident of what that pill looks like, please Google image it to make sure that you know what you're sending this child out with so that you're giving her the right instructions. There are 3 different ways to start a pill pack, okay? A first day start is when you take the first pill in your pill pack with the first day of your period. And sometimes for patients, that's just easy to remember. That would not be what I recommend for most sexually active teenagers. For them, I usually recommend that you do something called a quick start, which means they start it as soon as you send the prescription, okay? So that's the person, you know, you've got this 15-year-old who comes into you and she's having sex. She decides, despite all your counseling, that she wants to a birth control pill. You say, I just sent it to your pharmacy. What I want you to do is go in, pick it up, and take your first pill right there in the parking lot. Just take it today, okay? And then the problem with that is because you're starting mid-cycle potentially, you may have a little bit of breakthrough bleeding and spotting. So you need to warn her, this first pill back might be a bit funny, but things should settle out after that. But the reason to do that is because we know that up to 25% of young women, if they're given a prescription and say, just wait till the first day of your next period, they'll never actually take it. Okay, so it's just another way to help improve compliance. And this is maybe a place where you need to prescribe emergency contraception. And again, I'll talk a little bit about that later. Another common way that I will start a pill is a Sunday start. I tend to do this for my patients where I'm starting it for non-contraceptive indications. So if I'm starting it for like dysmenorrhea or acne management, something like that. And that just means that you begin taking your first active pill on the Sunday after your bleeding starts, okay? And the goal is that eventually as your body gets used to it, you will have no period on your weekend, which is kind of nice. The pill instructions are pretty simple. You're going to take 1 pill every day at the exact same time every single day. Clearly your patients are eventually going to miss a pill somewhere along the way. So I always make sure that I give them missed pill instructions, and I have this in handout form in my office. I'm happy to send it to anyone who wants it. So if they're going to miss a pill, they're going to take the pill that they forgot as soon as they realize it. So they may go to take Tuesday, Monday sitting right there. They may be taking 2 at the same time, and that's okay. If they miss 2 for 2 days, like they missed Saturday and Sunday, they're going to take 2 on Monday, 2 on Tuesday, and then things should be back on track. But if they miss 3 or more pills, I tell them they've missed too many. They need to stop with that pill pack, throw it away, get a period, and then start with a fresh pill pack. Anytime anyone misses a pill and they are sexually active, I recommend using condoms or abstaining for the next 7 days. So I think the pill is pretty complicated, despite the fact that it doesn't look like it should be. So I, in my personal practice, actually prescribe way more of the contraceptive patch. There are actually 2 patches that are out on the market. The most common one is Xulane because it has been out the longest, and actually Xulane had a generic release of it earlier this year. The generic sucks. I really try to avoid prescribing it. I get a lot of complaints from patients that it comes off. So if you're going to be prescribing Xulane, I recommend that you write that they do not substitute with generic. This is a cousin of the pill, right? It's got both ethinyl estradiol and progestin in it. This only has the 1 dose. It's a 35 microgram dose, and it suppresses ovulation in much the same way. The difference between Xulane and the pill is that instead of taking something every day, you're applying something weekly. Okay, and a lot of patients, that's a bit easier for them to manage. I do not tell my patients generally that it's forgiving and that hormone levels can remain therapeutic for about 9 days. I really try to avoid mentioning that, but that's good for you guys to know. And it has a lot of the other same pros that that the pill did in terms of its bleeding patterns, etc. The cons also are very similar in terms of estrogen contraindications and VTE risk. The big difference here is that skin reactions, about 3% of patients discontinue using the patch because they have some sort of skin reaction. And if you have a patient who is upfront and tells you that they have reactions to adhesive band-aids, that sort of thing, this probably wouldn't be the contraceptive method I recommend. There is a lot of data. The data is not unclear. I should update that. There was a black box warning that was released for Xulane earlier this year that says that they do not recommend Xulane for anyone with a BMI greater than 30 due to an increase in the VTE risk. I will say that the data that they presented shows that the VTE risk approximately doubles, but I did tell you that that VTE risk is about 5 out of 10,000 women. So we're taking it from 5 out of 10,000 to 10 out of 10,000. So 1 in 1,000, so 0.001% chance. And so in my personal practice, I have not stopped prescribing it for my patients with a BMI greater than 30. I tell them that there is this FDA black box warning, and if they want to proceed, then I let them proceed. I just document that. A lot of patients will say, oh, it doesn't work over 165 pounds. It's not that it doesn't work. It's that people over 165 pounds weren't tested in the clinical trials. And so that's just something to think about it. We do think there's contraceptive efficacy, but if you have someone who's morbidly obese, I would probably recommend something like an IUD as opposed to, or a depot, which we know isn't affected by obesity. When you prescribe Xulane, you're going to do the same start methods that you would for an OCP. I tell my patients to take a shower, dry off really well, and then before they put their lotion or anything else on, they apply it to clean and dry skin anywhere on the front or on the back. Definitely rotate your sites. And the number one question I get asked about this is it going to stay on my skin if I go to the beach, if I go to the gym, if I'm at basketball practice? Yes, 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 yes. If you put it on correctly, it is designed to stay on your skin. And then you can be as happy as this creepy woman staring at herself in the mirror. There are actually 2 rings that are out on the market. I do not have a huge amount of luck convincing my teenagers to get the other one, so I spend most of my time talking to them about NuvaRing. This is an actual NuvaRing here. You can see it's a clear silicone, very flexible ring that's placed inside the vagina. This again is a cousin of the birth control pill. It has a very low dose of ethinyl estradiol. You can see it's only 15 mics. And this is placed by the patient into her vagina, okay? And so I will tell you that generally I do not have high uptake with this with my teenagers. However, there are a couple of different ways that you can do this. They will tell you that if you're inserting NuvaRing, you are supposed to empty your bladder, wash your hands, fold it like a taco, and place it into the vagina where you can see if it's placed correctly. You shouldn't be able to feel it during sex because it's actually in that potential space around the cervix. So that anterior, posterior, and lateral fornices, it's like encircling the cervix like a collar. But what I usually tell my patients to do is take the tampon out of its applicator, fold that NuvaRing just like it is in the picture, pop that into the tampon applicator, and use that to shoot it up and get into the top of your vagina, okay? I don't have a cute trick to get it out. You still have to wash your hands and pull it out with your fingers. So for like all your girls who got them big old nails, this might not be the right method for them. And then condoms, 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 condoms. Y'all know if you've rotated with me, I love to give out condoms. I give condoms to lots of people at all my locations. I strongly recommend that when you go into your practice, if you have a generalist practice, you also give out condoms or have condoms available in your office because they are very expensive. And if you are a sexually active 15 or 16-year-old, that's a pretty big deal. And that in and of itself can be a barrier to care. The other big thing that I recommend that you do is rather than say something like, you use a condom all the time, right? Like clearly, what are they going to say? Yeah, totally. I totally use a condom every time. I will say something like, hey, while you're here in my office, I have condoms. Would you like me to show you how to put one on just to make sure you're feeling good about it or to see if I do it any differently than you? And they are almost always like, yeah, why don't you do that? Okay, so then I can show them how to put a condom on in the office. So I think that's another really important thing to do. Any questions about that before we zip on into emergency contraception? Y'all doing okay? Okay, so there are 3 FDA-approved forms of emergency contraception. There are 4 emergency contraceptive methods, and I will touch very quickly on the other one. I'm going to switch presentations just because I didn't actually include it in this one. So the first thing to say about emergency contraception is a lot of it is how you sell it. I had a patient of mine who got pregnant at 16. She had been on depot for a couple of years. She hadn't come in for her last 2 visits to get her depot, and she showed up to my office pregnant. And I was like, what happened? And she was like, oh, well, you know, I had broken up with my boyfriend, so I didn't think I needed the depot no more, so I didn't get it. And then I met this new guy, or I got back together with my old boyfriend or whatever, and we had sex and we didn't use a condom, and here I am. And I said, well, what about like Plan B or emergency contraception? She goes, I don't believe in abortion. And I was like, it's not an abortion drug, right? Emergency contraception is birth control that works after you have sex. And she like burst into tears in my office and she went, the internet lied to me. It was like horrible. It was horrible. And then I delivered her baby prematurely, actually, a few months later. So it was really crap. But realize that that's the thing, right? A lot of people think that emergency contraception is an abortion drug or it's performing an abortion, and it's not, okay? So this is birth control that works after you have sex, and you have to say that like 6 times to make sure they really understand it. The one that I think most people are familiar with is Plan B one-step, specifically Plan B one-step. Most of you guys probably don't remember that when Plan B was originally released, it actually was a two-step process. You were supposed to take one pill and then repeat it 24 hours later. The problem was everyone puked their guts out then for 48 hours. So they consolidated it, and now it is one pill that you take one time within 3 days of unprotected sex, okay? Now, hypothetically, this is available over the counter, though I would encourage you guys next time you're in a pharmacy to look for the Plan B. It's actually a lot harder to find than you think. I've seen it in lots of different places. I've seen it on the shelves. I've also seen it behind the pharmacy counter, so you have to go up to the counter to ask for it. I've seen it on the shelves in a lockbox, so you have to ask someone to come and unlock it for you so that you can access it. I've seen it behind the counter on a top shelf, so that if someone was going to get it for you, they would have to go get a ladder and then climb up to go get it. So that's pretty interesting, right? If you're a 15-year-old and you're asking for Plan B, or let's make her 16, that can be hard to access. So over the counter, but maybe not always as available as we think. And the other problem is it's pretty expensive. Okay, so I don't know if you've ever looked at the prices of Plan B, but around in South Carolina, the average price I've found is anywhere between actually $50 to $70. I've seen it cheaper, but it can be pretty expensive. The other problem is we don't know how effective it really is after 165 pounds. And so if I have a patient who can't access me for whatever reason, or this is the way that she's going to use an emergency contraceptive and she weighs more than 165 pounds, I'll tell her to take 2. Just to be sure. The way that it works is it delays follicular development and rupture. Okay, so it really just pushes that cancer. Remember that when you're ovulating, you've got this follicle that's getting bigger bursts and releases the egg. What it does is it delays that by 24 to 48 hours. So that gives the little spermies time to die. The one that I prefer is Ella. Ella is another one that inhibits follicular rupture. It's one pill that's taken one time. And I like it because it's good for up to 5 days after unprotected intercourse. It's more effective, greater than 165 pounds. But the problem with it is available by prescription only. And so that can be another barrier. So in my personal practice, what I do is if I have a patient who chooses a patient-dependent method of contraception, so like a pill patch ring, and for some of my kids, Depo, I will always print them a prescription for Ella, and I will put a refill on it because it's good for a year. And I tell them to fold it up and put it in their pocket or in their purse. You never know when you might need it. It's okay. But then what you can do is you can go to the pharmacy, slide it across the counter, and it's cheaper, and you don't have to go through the song and dance of getting someone to unlock the Plan B for you so that you can get it. The big problem with it, particularly in South Carolina, is not all patients carry it, or pharmacies, not all pharmacies carry it, which is really problematic. We 100% always have it in stock over at 14 Medical Park, and the cost there is $23.30. Okay, so cheaper than Plan B by half. And so I always tell my patients that the best deal in town is at 14 Medical Park Pharmacy. If you ever need this, please go there. And it's actually amazing. You know, every year I'll see someone and I'll say, "Did you ever use that Plan B?" And they'll go, "I did." Can I actually have another prescription for that? Yes, absolutely you can. Or not Plan B, that LS. So like this is something that teenagers do use. So please consider giving that to them. And again, even when you're in like a private practice or a generalist peds setting or ER guys, you know, or say you've got, or what about when you've got a kid who's got complex congenital heart disease, right? And the last thing you want her to do is get pregnant, and she comes into your office because you're a cardiologist, and you ask her because you know you're supposed to, when was her last menstrual period? And she goes, "I don't know, it's been all over the place. And then I had sex last night, and I don't know, maybe I wasn't supposed to." Bah! This is totally something you can give her, right? And then call your friendly neighborhood pediatric gynecologist and be like, "You need to get my kid in because she needs birth control." There's lots of other stuff, right? Most of the other stuff is a little bit experimental. Much of it is quite gross. I'm not going to spend a whole lot of time talking about it. I have gotten a lot of questions recently about male contraception. Yes, there is male contraception in the works. It should be coming out in the next 5 to 10 years. The two that are showing the most promise right now is there is like a male gel that's rubbed into the shoulder, much like a testosterone gel, but it works like a male birth control pill. So that's doing really well, but actually a little further along in the clinical trials is a male LARC method, which is actually pretty cool, where they inject a it's like a occlusive gel into the vas deferens, so that you have blockage of like sperm. I don't know how they reverse it. They're being a little hazy on the details, but yes, it's happening, y'all. It's in the works. So male contraception may be coming. Okay. If I start a teenager on a contraceptive method, I generally see them back in 3 or 4 months, because what I don't want to have happen is they're like, oh my God, I gained all this weight and like my hair started falling out. So I'm totally clearly allergic to it. So they just stop. And then you've told them you're going to see them in a year and they only took something for two months. And then you've missed that opportunity. So I usually have them come back in about 3 or 4 months, make sure that things are going great, and then I see them annually. And then just remember, particularly if they're sexually active, to make sure you're getting that STI testing that's in there. The other thing I would encourage you guys to do, and I know it's hard for you because you don't bill in your offices, but you will bill in real life, I promise, is making sure that you're using appropriate codes, because this will sometimes get you in trouble. And I see this when I have residents rotate with me. So particularly at 1801, like you might have had a 14-year-old who comes in for dysmenorrhea, right? And the MA put birth control here for birth control. And so the resident goes, okay. And so they put birth control education. And then I get this angry phone call from a parent going, what do you mean birth control? My daughter's not on birth control. She's not having sex. Like, do you know something I don't know? The right code probably would have been dysmenorrhea, right? To code that to, or on oral contraceptive pills for a non-contraceptive indication. That's another great code. So just making sure that you're thinking about your code. And I have to be very cognizant of my codes because of that Blue Cross Blue Shield state situation, right? So if I have a 14-year-old with dysmenorrhea, I have to go through all these hoops with prior auth, et cetera, with her insurance company. I have to code those pills to the dysmenorrhea because I have to show it's not that she's sexually active. And then when she comes back next year for her annual surveillance, I'll say something like on oral contraceptive pills for a non-contraceptive indication so that I can speed up that PA process. It's a really big pain in my ass. Last but not least, making sure that you know where people can get access. So I talked a little bit about the Walmart $4 list. So if you have a self-pay patient, that's Sprintech is on there, do it. Great, easy. I've already talked to you about the Choose Well program that we have over at 1801. Please use us. We're there for a reason. And then the Prisma Health Pharmacy over at 14 Medical Park. Wow, this is a really old slide set. I should update this. Is also another really good one. And then when contraception isn't an option, what do you do? Contraception, I know, isn't always an option for you guys, right? Either because you have an attending who isn't comfortable with it, you don't have all of the things in chalk, maybe people aren't comfortable for whatever reason, training, religion, whatever. Just try and think about how you can help your patients, okay? So say you have someone who comes into you for contraception, for a contraceptive consult, and they don't realize that you're not going to write it for them. It's still reasonable to counsel them on all of their options. So maybe by the time they get to see me, they've already thought about it. You've given them some handouts from those resources that I told you so that they come to me and they go, actually, I went in to see Dr. X thinking I was going to get a pill, but he talked to me. I actually think I want that thing in my arm. Great. Really helpful. Make sure that you're giving them information. Consider writing them for a prescription for emergency contraception. So say you have a sexually active teenager and there's just no way that your attending is going to let you write a prescription or whatever. Maybe just giving her a prescription for emergency contraception so she's not stuck and doesn't get pregnant while she's waiting to see me. That would be really good. You could consider making access in your clinic. I was at a community pediatrician office not that long ago, talking to them about Nexplanon because a lot of the women in that office really wanted to be able to put those in because they thought it was straightforward. And you guys have now gotten your Nexplanon training. It's pretty straightforward, right? So that was something that didn't happen 2 years ago. Okay. So we've worked really hard to make some access for that for you guys. So thinking about that. And then if you have any sort of like moral, religious exemption for the provision of contraception, that is fine, but maybe check your schedule ahead of time, right? So that way, at least if you have a kid on your schedule and she's coming to talk to you about contraception, you can switch with your partner, you can get her rescheduled, whatever the case may be. Okay. I'm done. This is a really cool picture. She doesn't look very happy. This is my mother-in-law. So my husband is Irish, and in Ireland, contraception wasn't legally available until the late 70s. And then it was only legally available for married women. And my mother-in-law was like this amazing pioneer. Look at her like marching up and down in front of the Irish Parliament with her like thing that says family planning is a basic human right. Anyway, she's pregnant with my husband in that picture, but anyway. All right, y'all. What questions do we have? We're finishing bang on time. What questions do you guys have?
For placing the implant, do private pediatricians ever do that, or is that more of an OB/GYN thing?
Absolutely. I am in no way trying to throw anyone under the bus here, but I will say I've practiced in a number of different environments, and Columbia is the only environment I've worked in where pediatricians don't prescribe contraception on a regular basis. The only environment. In my last environment, pediatricians put in Nexplanons. A lot of them would refer for the IUD, reasonable, but the adolescent guys would put in the IUD. So like their equivalent of CHOP would send to their adolescent department to put in the IUD. They never even met GYN. So yes, realize that you guys are in a bit of a cultural bubble in your current location. It is not like this universally. So yes, I know plenty of pediatricians who put in Nexplanons because it's easy. And guess what? When you're in community practice, you're going to make 3 times more money putting in one Nexplanon than you are seeing your next 6 well child checks for a lot less time. So there's a lot of financial motivation to put in Nexplanons as well.
Thank you.
Mm-hmm. Well,
Dr. Tomlin, thanks for the presentation. Real quick, just because there's been some questions about this, what is the best way inpatient wise to consult like pediatric GYN if we need to get them involved?
Consult the GYN team.
Okay. How do we, do you guys have a telemedic or how does?
Yeah, we're trying to change it so that the telemedic reflects there's a GYN team. There's actually a GYN pager.
Okay.
We're working on it right now. It's hard because it just lists the attending on, and that's harder for us. But just consult the GYN team.
Okay.
And you can just page them. Worst case scenario, you can always call LND and be like, "What's the GYN pager number?" And they'll happily give you the GYN, so they don't have to deal with it. And then usually what happens is if it's something what my partners can handle, like if they feel like it's reasonable, they'll handle it. If they think it's something that I need to see, like if it's kind of specialized peds, they'll call me.
Okay. Thank you.
Mm-hmm. What else? All right, y'all. Enjoy your weekend.